Switzer, for giving that introductory presentation, and thanks for AMET Melanoma for pulling the symposium together. I'm Gyorgy Paragh. I'm a dermatologist here at Roswell Park, and our goal here in dermatology is actually to keep you out of the hands of the oncologist. So I'm actually going to talk about what I say is molar monster, diagnosing melanoma, detecting melanoma early, and predictors of risk. In my talk, first I'll talk about incidence, melanoma in numbers, then we'll briefly talk also about the origin of melanoma and melanocytes. We'll talk about who's at risk for developing melanoma, the major risk factors, and then we'll discuss subtypes of melanoma because that's very important to know in order to be able to recognize disease. Then we'll talk briefly about benign pigmented and non-pigmented skin lesions, because obviously melanoma doesn't come on perfectly normal looking skin, and therefore it's important to understand the other lesions that we need to differentiate them from. And then we'll talk about the morphological features that enable us to diagnose melanoma. And then we'll talk about how we actually diagnose melanoma out of the lesions that look suspicious. First, let's talk about incidence. As Dr. Switzer also alluded to it, melanoma incidence has been rising very rapidly in the last decades. The silver lining, however, is that luckily in the past few years, we've at least seen a slight reduction in melanoma mortality rates. Nevertheless, currently we diagnose annually over 100,000 invasive melanoma cases, and melanoma results in over 8,000 deaths annually. And because of this, currently the lifetime risk of developing melanoma is over 2% in the US population. The median age of diagnosis is 59. And unfortunately, although melanoma is more common in older individuals, it is the most common cancer in young adults between the age of 25 and 29. Because of the very high incidence, we currently have almost 1.5 million people with a history of invasive melanoma. And it's important to realize that this really only captures invasive melanoma, because when it comes to non-invasive melanoma, that's not even captured in these numbers. Melanoma in situ, we also diagnose approximately 100,000 cases of each and every year. So if you added all that, we actually have a lot more patients who have been affected by melanoma. Again, I already mentioned that the only good thing is that we actually capture quite a few of these melanoma early, and because we capture them early, luckily the mortality rate has been decreasing, and also it has been decreasing because of better therapeutic options. As early diagnosis is key, next we'll talk about the origin of melanoma, and then we'll talk about the features of melanoma to essentially enable everyone to possibly diagnose melanoma early and earlier. Melanoma originates from melanocytes. Melanocytes are the cell type that produce pigment in our skin. And these melanocytes are responsible for all the shades of color that we see in our non-sun exposed skin. Their normal function is to reduce sun damage to our skin by producing more pigment. But in that process, they can also themselves be damaged, and then because of accumulating damage can undergo uncontrolled growth, resulting in the formation of melanoma. As the damage is crucial, we very well understand that melanoma is majorly triggered by prior ultraviolet light damage and accumulating mutations in pigment cells, similar to other skin cancers, but obviously other skin cancers are triggered by accumulating mutations in other cell types within our skin. Because of the importance of UV exposure, obviously UV exposure is also a very well-known and important risk factor in melanoma. Sun exposure and indoor tanning are both understood to be important risk factors, but it's also important to realize that it's not only the amount of UV exposure, it's also the mode of UV exposure that matters. And we clearly know that bad blistering early life sunburns are a very important factor in, for example, superficial spreading melanoma, the most common subtype of melanoma. We also understand that it's not only sun exposure, but also some personal characteristics that are important in melanoma risk. Large number of nevi, a large number of atypical nevi, a large congenital nevi also put people at increased risk. Very fair skin, kind of red hair, blue eyes, freckled skin, inability to tan puts people at increased risk also. A family history of melanoma and also family history and personal history of other skin cancers can put people at also increased risk. Melanoma risk increases with age, But again, do not forget that unfortunately melanoma does not spare those of us who are younger. Male gender is an important risk factor. Men are almost twice as likely to get melanoma than women, but again, there are different sort of age characteristics to this. And we also understand that a weakened immune system can put people at an increased risk of developing melanoma also. But I want people to understand that not everyone has obvious risk factors to develop melanoma. Some melanomas come in areas that are hidden, that are not sun exposed, that are mucosal sites. Some melanomas can come in the depth of the eye, and some melanomas can form actually without even a prior skin lesion being present. Some melanomas may pop up in the lymph nodes or even at distant sites. So again, what I'm going to talk about is obviously going to be mostly cutaneous melanoma and how you can recognize it, but we should not forget that not all melanomas show up in these sites. And even if someone does a superb job with this, we can't unfortunately capture all melanomas early enough. Again, in order to understand melanomas and to be able to capture them early enough, I think we have to talk also about subtypes. All of the melanomas come from pigment cells, but although they come from pigment cells, they can look quite different based on the subtype. These are the major subtypes. First, we'll talk about superficial spreading melanoma, then nodular melanoma, after that acral lentiginous melanoma, and then lentigo-malignant melanoma. Superficial spreading melanoma is the most common subtype, responsible for approximately 70% of the cases. And it usually is the melanoma that presents earlier in life. It can arise either as a brand new lesion on the skin, as we call it de novo, or it can also show up in pre-existing moles. It's important to realize that this is the subtype that's, again, very common, but is also often driven by intermittent large amount of sun exposure. So it's actually fairly common in areas of the skin where people burn, but don't necessarily get most sun. For example, the back, middle of the back, or the calves in women. Superficial spreading melanoma after an initial phase of growth goes through a slow, usual radial growth phase. Then the border irregularity increases, areas of regression appear, after which, again, months to years later, usually the vertical growth phase starts taking place where the melanoma starts spreading deeper. It's important because usually as melanoma starts spreading deeper is when you can start seeing the risk of metastasis increasing, and therefore in superficial spreading melanoma, often we have more time to catch it early than in some other types of melanoma. These are also the melanomas that many of the features that you may have heard of and that we'll talk about later can be recognized easily on: the asymmetry, the border irregularity, the color variation, the increased diameter, and the evolution. Next, we'll talk about nodular melanoma. Nodular melanoma is the second most common subtype. And it is responsible for approximately 15 to 30% of cases. It is more common later in life. This lacks that radial long growth phase. Therefore, often we don't have the luxury of catching it as early unless someone is paying very close attention to their skin, because this is one that usually will start with rapid vertical growth and therefore is often recognized later when it's thicker and then there's poorer prognosis. This shows, again, a male predominance. And it is very frequent on the trunk, head, and neck. And this is more common in the highly sunburned areas of the skin, and it's not as much driven by intermittent sun exposure as the superficial spreading melanoma subtype. These are some of the images of nodular melanomas. It's important to recognize that sometimes in nodular melanomas, you see the underlying sort of precursor lesions. Occasionally, you don't see anything. You just see sort of an ulcerated tumor. Sometimes they are large. Occasionally, they are much smaller. And sometimes they are actually harder to differentiate from just atypical nevi. And occasionally, they can also lack pigment or only have very subtle pigmentation, or may even only have a bluish hue to them, as opposed to sort of commonly people thinking of melanoma as a brown or black lesion. Next, we'll talk about acral lentiginous melanoma. This is a subtype that's very important to know about because we should not forget that, again, not all melanomas come in sun-exposed area of the skin. Acral lentiginous melanoma comes on acral surfaces, so the palms and the soles, We'll see a couple of images later on. Usually it will present around the nail unit or in areas of possible trauma on the palms or on the soles. It usually comes later in life, but can come also earlier. And this has a similar incidence across all pigment type groups. And because of this, this is actually the predominant melanoma in darker skinned people. These are some images. You'll see here an acrolentigenous melanoma affecting the great toe, causing discoloration in the toe. Often these will show up as initially just color change under the nail, and later on can spread to the surrounding nail fold. And occasionally, again, it can also show up on the plantar or palmar surfaces as a large growing black to brown patch. Occasionally, they can ulcerate. Next, the last sort of major melanoma subtype that I wanted to discuss is lentigo malignant melanoma, or malignant freckle. The lentigo malignant melanoma is one of the subtypes that goes through usually a very slow radial growth. It often happens and often comes in highly sun-damaged areas of the skin. The trick with this melanoma subtype is that often as it grows fairly slowly, people may remember something having been there for a long time. And this is where I think now cell phone photography can help people tremendously, because if people look at something that looks odd, they are unsure of sort of what may have happened in that area, and they go back to photos that they may have on their cell phones from 5-10 years ago, and they establish that subtle, insidious, slow growth, again, that may alert them to a possible lentigo malignant melanoma. Or lentigo maligna. It starts again with a radial growth phase, then it's a malignant freckle only the top of the skin, and then later, often after a decade, sometimes even 2 decades, it will go through a conversion into invasive growth and will form a lentigo maligna melanoma at that time. This represents approximately 4 to 15% of melanomas, and again, this usually happens in highly sun-damaged areas of the skin. These are some of the images. And again, initially it will spread laterally and will grow radially and will cause pigmentary change in the skin. And then later on within these areas, bumps can appear that can sometimes be black. Sometimes they can also have bluish features. Occasionally they can look pink even. That will signal that the melanoma has gone beyond just being in the top of the skin and has been able to spread underneath. As I mentioned previously, early diagnosis is key, and early diagnosis is key because the earlier we catch melanoma and the thinner it is, the less likely that it will spread, and the easier it is to keep you out of the hands of oncologists and to just take care of the melanoma with surgical means. But in order to understand early diagnosis, we need to be able to differentiate pigmented lesions and problem pigmented lesions from benign lesions on the skin. Because don't forget that unfortunately the Photoshop fake images in the media are not reality. Our skin is littered with normal skin lesions, and we really need to identify problem spots against this background. We have numerous benign non-melanocytic lesions that can look pigmented, like seborrheic keratosis or stockokeratosis. We have red spots in our skin, like cherry angiomata. We can see purple spots, which can be oftentimes just purpura on our skin, or we can see scar-like lesions like dermatofibromata that again can resemble some melanoma subtypes. Then we need to differentiate problem spots from these lesions. And obviously we also even have quote-unquote moles, so melanocytic lesions on our skin that are completely benign, which are just local proliferations of pigment cells, which are again common, benign, which can be congenital nevi, that can be present from very early on or even from the time of birth, can be small or large. Occasionally they can even be speckled. They can also be acquired. Sometimes they are dark in color, occasionally they are pink. Sometimes they can have multiple features, a bump in the center and sort of flat areas around. And occasionally they can even have some pigment variability within them. Sometimes they can even have very striking signature on the skin when multiple similar appearing but very striking appearing nevi can present in individuals. And occasionally can even present with features that are reminiscent of some early melanomas and can even have histological features of atypia. But it's important to realize that the vast majority of these moles, of these pigmented lesions on our skin, will not turn into problem spots. And these are essentially benign. When it comes to completely benign nevi that have no features of histological atypia, the chance that they convert into melanoma is somewhere around 1 in a quarter million. When it comes to atypical nevi, sort of run-of-the-mill atypical nevi, that chance is only 1 in 40,000. So that's the reason why we actually consider these benign, and our goal is to differentiate melanomas and sort of very early melanomas from these pigmented lesions that are, again, completely harmless. What enables us to differentiate them? What are these morphological features? I think you probably all heard of the ABCDE. These are truly time-tested features of recognizing problem pigmented lesions. The ABCD criteria were published in 1985. E was added in 2004. And again, they all withstood the test of time. When we talk about the ABCD criteria, we talk about asymmetry. So one half of the mole looks different than the other half. Border regularity, instead of a nice smooth transition over into the surrounding skin with sharp edges, there's fuzziness. There are almost like legs going into the surrounding areas. Then color variability and color variation, where you see multiple shades of gray, blue, black, tan, pink in the lesions, again, raising the concern that the lesion may be actually an early problem spot. Diameter, often problem spots tend to be larger, and evolution. Obviously, something that's pigmented and evolving is much more likely to be a concerning spot than something that has been staying put and completely unchanged for decades. One other thing that I love to add to these is, which we often forget about, is the ugly duckling sign, whereas I often tell my patients, and some of you may have heard, the F feature, so that makes it A, B, C, D, E, F, funny or funky. Ugly duckling sign means that usually melanomas are going to be singular on someone's skin. So when you see something that's really odd, that stands out of the crowd, that looks very, very different than anything else, obviously that is probably the problem spot that we have to focus on. And this, I think, is a great cartoon about the ugly duckling sign. But do not forget that these features do not describe all problem spots, because some of the melanomas are going to be pink and maybe fully pink, or may only have minimal grayish tones to them. Therefore, in order to really capture all problem spots, we actually often use additional features that we take from sort of the non-melanoma skin cancer handbook, which are also important anyhow, because if someone has a history of melanoma or is at high risk of melanoma, they often will be also at a much higher risk of developing non-melanoma skin cancers. And these features are growing pink papules. If someone has something that's slowly growing pink, but progressing, that can actually also be sometimes a sign of skin cancer. The majority of these are not going to be melanomas, but sometimes melanomas can also show up like this. Sores that do not heal can also signal possible skin cancers. Skin areas that bleed frequently after little trauma can also be a sign of underlying skin cancer, and spontaneously appearing growing scars can occasionally also signal cancerous lesions in the skin. How do we catch these? One of the things is that it's not us only who will be catching these. I really think that self-skin check in individuals who are at very high risk is absolutely crucial and is of paramount importance. But one thing that you also need to realize, that self-skin check should only be self. I always tell everyone that yes, these brochures that show you how to use 2 mirrors are great, but when you imagine how easy it is to look at your own back with 2 mirrors, you will soon realize that best is to actually ask the help of a loved one to look at your back, look at the back of the scalp, and help actually do self-skin check with company in order to make sure that you can capture possible problem lesions earlier. Once a possible problem lesion is identified, obviously we still need to diagnose it. For that, we recommend that you go to a professional. it's best to go to someone who uses dermoscopy, who actually looks at these lesions under magnification with polarized and non-polarized light to be able to identify other features that with the naked eye, none of us can see. And I'll tell you, I feel completely lost without my dermatoscope. I travel with it because if anyone stops me and asks me about something, I feel that I can't really comment on the truly important features. And after we see something that truly looks concerning, even on dermoscopy, obviously we still need to prove that. And how do we prove it? We do a biopsy. We usually will prefer complete removal of the lesions with excisional or complete shape biopsies, but occasionally when the lesion is very large, we'll still opt to do incisional or punch biopsies of larger areas. And obviously after that, we need the pathologists to help us because they are the ones who ultimately will help us diagnose these lesions. And you'll hear more about that in the next talk. So in summary, I talked about incidence, recognize that unfortunately melanoma incidence has been rapidly rising, but do understand also that there's a silver lining because mortality rates luckily have been dropping. Also understand that melanomas come from pigment cells, but remember that not all melanomas, although they come from pigment cells and they are based on mutated pigment cells, not all melanomas will be dark and pigmented. Do know that higher level of prior sun exposure, lack of prior sun protection, bad early life sunburns, fairer skin puts people at increased risk. Also remember some of the subtypes, and I want to highlight also that some of the melanomas come in intermittently sun-exposed, previously badly sunburned areas and not the most sun-exposed areas of the skin. And also remember that occasionally melanomas can come up in areas that have not really seen sunlight previously at all. Remember also that there are many pigmented skin lesions that you need to differentiate problem lesions from. Remember the A, B, C, D, E on morphology, and don't forget the ugly duckling sign or funny and funky lesions. And also remember that after you recognize something, it's important to talk to a professional and actually establish a diagnosis early so that it can be treated and curatively removed with surgery so that you don't have to see our oncology colleagues. With that, I wanted to thank you all for the attention, and I wanted to actually have Dr. Andia continue with the talk about the sort of the point of view of a pathologist.